All right. Let me know if you guys can see my screen.
Yes, we can see it.
Yes,
Okay.
definitely.
All right, good. Oops. All right, perfect. Let's get started here. So today what I want to do is cover some stuff in immunology as much as we can, and we'll take it from there, okay? So let's get started with your immune system organs, okay? What you need to know about this is, one, you have what's called your primary organs and you have your secondary organs, okay? The primary organs are going to be the areas of immune cell production. So be it your B cells, your T cells, all that kind of stuff. If you're making it there, it's a primary organ, okay? Your secondary organs are not for production, but for interaction. The whole concept of immunology is to react to antigens, right? Is for your body to be able to react to antigens that it's been exposed to and fight them. So first, you must make the immune cells. Second, you must bring the immune cells and the antigens in contact. So that's the key thing here. And you see this terminology again as we proceed. But the primary organs is for production, and the secondary organs are for interaction. Key point. Okay, so your secondary organs, we're looking at like your spleen, your lymph nodes, your tonsils, your Peyer's patches. They are just for interaction between your antigens and the cells that would respond to them, at least for initial recognition before we mount a widespread, wide-scale immune response. Okay, so remember that. So lymph nodes, spleen, and all that, secondary organs. The main primary organs is your bone marrow and your thymus. Bone marrow is for your B cell maturation, thymus for your T cell maturation, all right? But bone marrow makes everything at the end of the day. So let's go into the lymph node. Like we said, the lymph node does not make anything, right? So if you look at it that way, right? If you look at it that way, it's going to be a secondary lymphoid organ, okay? And as you can see, we're going to look at the picture shortly. It has many afferents and some efferents, which we're going to talk about the roles that they play. Now, what are the key things you need to know about the lymph node? We all experience this, right? When you get sick, you get infected somewhere, you tend to have the lymph nodes in that area, the localized lymph nodes, they get enlarged, right? And why is that happening? It's because there's an activation going on in that lymph node to fight the infection in that area. So obviously, in your lymph nodes, you have B cells, you have T cells, okay? And also you have macrophages. The key thing for you is to know what are the different parts of the lymph nodes and where do I have these different structures, okay? So starting off with the follicle, okay? Your lymph nodes have what's called your follicles, okay? And that's why sometimes there's going to be a connection between this and hematology and oncology, right? So for example, when we talk about the follicle, you can hear terms like follicular lymphoma, okay? So then you can make the connection, all right, that this is the origin. But what's the deal? Your follicles are unique to your B cells. That's the take-home message there. Your follicles are unique, right, to your B cells as far as your lymph nodes are concerned, okay? So, but the key thing here is it is not B cell production, okay? Because this is a secondary lymphoid organ. B cell production remains in the bone marrow. This is just for B cell localization and proliferation, okay? So that's what your follicle is. And if you look at the picture, you can see your follicles, they're easy to pick out, right? They're round and they're in that outer region right there. If you look at this picture, that's your follicle. Now, there are two types of follicles. You have what's called your primary follicles and you have your secondary follicles. Your primary follicles are considered dense because they don't have a ring structure, right? They're filled up. When it's filled up like that, that's a primary follicle. Okay. But if the follicle looks like this, right? If it almost looks like a red blood cell, then that's the secondary follicle. Okay. The ones that we care about are the secondary follicles. Okay. Because they look like red blood cells, they have their ring structure. So obviously the center of it is pale, right? That pale center of your secondary follicle is called your germinal center. Okay. Now, hear this. Your germinal center is not unique, right, to your lymph nodes. Germinal centers can also be seen in the spleen, okay? So the moral of the story is your germinal center is a site of B cell production, okay? B cell production is for your germinal center. So going forward, wherever you see germinal center, not just lymph node, remember that that's an area for B cells, okay? Let me see if it actually even says it here. Well, it doesn't, right? So it says your pale central germinal centers are active. The word active, when they mean they're active there, it means that we have B cell activity, all right, in the germinal centers. And the activity there obviously is localization and proliferation. All right, now your primary follicles, right, they're dormant, they're not really doing much, okay? So that's that. Now, obviously, the other kind of cells, I'm going to skip around here. The other kind of cells are important. Now we know where the B cells are. They're in the follicles, specifically the secondary follicles, specifically the germinal center, right? Well, yeah, and I should actually also mention this. The outer part of the ring of this your secondary follicle is called your mantle zone. Okay, your mantle zone. So you're going to come across a time when you go forward called your mantle cell lymphoma, with your translocation 1114, if I remember correctly, all right? That's a lymphoma originating from the mantle zone of your follicles, okay? So obviously that tells you that your mantle zone also has B lymphocytes, but the lymphocytes that are found here, the B lymphocytes that are found here are called transitional lymphocytes. The transitional B lymphocytes. Can't spell today again.
And you're saying that's in the mantle zone, correct?
Yes, that's in the mantle zone.
Okay.
Right. Your transitional B lymphocytes, and then your regular B lymphocytes be in the germinal center, right? So the germinal center, right, starts the whole activity. That's where everything starts, and then they move outwards towards the mantle zone, and then out of there from the follicle from there. Okay, so that's for your B cells. Okay. Now, what about your T cells? I'll come back to the medulla. But now we know where the B cells are. Let's find the T cells. Okay. Your T cells are located in the area called your paracortex. Okay. Your paracortex is where you find your T cells. And in the picture right here, you can see it right there. So it's close to the center of the lymph node. Okay. It's close to the center of the lymph node, but what it does for you is it separates, it's an intermediate zone, right? It separates the follicles from the medulla, which is why I wish they'd had it the other way around in this book, right? But if you want to go from outside to inside, you should go 1, 2, and 3 right there. So it's follicle, right? Then paracortex, okay, before the medulla. Okay, because the medulla were coming towards the center and out. So T cells, paracortex region, we know what T cells are for, right? Mainly for fighting viral infections and all that. We'll talk about that shortly when we get into the different types of your immune systems. Now, something else you have in the paracortex is what's called your high endothelial venules, okay? For short, they're called your HEVs, right? You may come across the acronym HEVs, same thing, okay? Now, what are high endothelial venules? High endothelial venules are post-capillary venules as well. So in this picture right here, this is your HEV that they're trying to show you, right? So sometimes called your post-capillary venule, right? It's the same thing as your high endothelial venule. And the reason why they're called high endothelial venule, let me zoom this out, see if you guys can see it, is they have what's called like plumps, okay? That's just their structure. They're not smooth, okay? They have like these bulging areas, okay? Structurally, that's how you identify them. So because of those bulges, they're considered to be high endothelial, right? Because endothelial cells, remember, endothelial cells of capillaries are usually flat, right? That's what we expect histologically, is that endothelial cells should be flat. But when it comes to your HEVs, the endothelial cells are not flat, they're bulky. That's why they're called high endothelial, because the cells are not flat, they're high, okay? And you find them in this zone as well. So what's the role of your high endothelial venules? Okay, first things first, know the structure. They're not flat, they're bulky. But number two, they actually help you bring your B and T cells from the blood. It says it right there, from the blood. So your B and T cells are coming from the blood. Now the question is, why are B and T cells in the blood? Because your B and T cells were made in the bone marrow in the first place. The T cells got matured in the thymus, but they're not going to fight an infection in the bone marrow. They're not going to fight the infection in the thymus, right? They need to fight infection somewhere else, but they have to recognize what they're fighting. The spleen is your meeting place, because remember we said your secondary organs have one job, and that one job is interaction. Okay, so your secondary organs are the meeting place for the bad guy and the good guy. When I say bad guy and good guy, I mean that's the meeting place for the antigen and the immune cell. They have to meet in a secondary organ like the lymph node. Okay, so what happens is, let's illustrate it. Let's assume you have strep throat or something. Okay, you get an infection in the throat area. What's going to happen is antigen presenting cells will pick up whatever they can. And we're going to talk about endogenous versus exogenous antigens shortly. But the antigen presenting cells will pick up what they can from that antigen, right, in your throat region. And through your lymphatics, not the blood, but through lymphatics, which typically we like to use a green color for lymphatics, your afferent lymphatics will bring the antigen in to the lymph node. Remember that. Your afferent lymphatics will bring the antigen in. Okay. So now we have brought in the bad guy to the meeting place, and the meeting place is the lymph node. So we also have to bring in the good guys, which is your B and T cells. And who's going to bring them in? Your high endothelial venules will bring in the good guys, coming in that way. And then once we do that, we can now have an interaction inside of the spleen between the antigen and the B or T cell. And then once they meet and recognize each other, then you're able to mount an immune response. It is when that meeting starts that lymph node will say, you know what? I recognize that this is strep throat. Okay, I know how to deal with this. I have some memory B cells I can use to take care of this. What happens? The memory B cells begin to proliferate, and now your lymph node becomes big. And that's when you can touch your neck and say, oh, I think I have sore throat, right? My lymph nodes in my neck are enlarged. That's the whole concept here. That's what your lymph node is all about. It's a meeting place for the antigen and the immune cells in order for them to interact and start the immune response, okay? But remember the kidneys that play the role. So obviously your afferent lymphatics are for bringing in the antigen, but your high endothelial venules, your HEVs, are for bringing the immune cells, which is your T and your B cells. So what's the problem that we can have here? Like it says, this area is not well developed in patients that have DiGeorge's syndrome. That is why DiGeorge's patients can be prone to infections. Okay, they can be prone to infections. And also, you know, outside of all of this, don't forget your DiGeorge's syndrome patients also have poor development of the thymus, right? So that's something else that you can see right there. All right, so that's your paracortex, okay? And whenever you have an immune response, right, going on, then your paracortex can enlarge, okay? And then you get the lymphadenopathy, okay? Now, keyword here is, this is when you're mounting a cellular immune response. And cellular immune response means that we're using the cells, the lymphocytes, your B or T cells, okay? So that's it. And then finally, the last zone there is obviously going to be the medulla. Nothing big about the medulla, right? It's an area for all the sinuses and cords to interact, right? The medulla pretty much has two main structures there: your medullary sinuses and your medullary cords, right? And the cords is pretty much just a bunch of lymphocytes packed together in plasma cells, right? And then you have your sinuses, which is like, you know, your blood vessels. The bottom line is, once we're in the medulla, we're getting ready to leave, okay? And that's how stuff actually comes out, all right, through your efferent lymphatics. And now we can go around, get to the right place and fight these infections. So that's your lymph node in summary, okay? Always remember, it's a secondary organ, so it's just for interaction, all right? So always remember who is interacting. The interaction is between my antigen and my B or T cells. Okay. So afferent lymphatics will bring my antigen in. High endothelial venules will bring these ones in. Once they meet each other, they shake hands and they fight. And that's it. All right, so this page right here, I'm not going to go through this, but this is something you should take your time and review. And don't lose sleep over this trying to memorize all of this at once, okay? Get the concept. The concept is there are lymph nodes located in specific parts of our body, okay? So once you know the lymph nodes, right, that's the easier way. Then if you're given a scenario, just need to figure out what's closest to that location, that what's the lymph node closest to what is going on, and that's most likely where you're going to drain into. All right. So for example, when you look at this is like a very the popular one, right? Your deep cervical and also your submandibular, right? These usually have to do with, like, areas in your oral cavity, your head and neck. So like when you get things like sore throat and upper respiratory tract infection, mononucleosis and all that is going to come around there. Okay. So it's just easy to look at it that way. So this is all purely anatomy. Know the locations of the lymph nodes. And if you're given a scenario where they give you something, a part of the body, then just remember what lymph node is going to be closest to that area. Okay. One key thing I should emphasize, that it's not here, but you guys need to notice is, when you look at this picture of the lymph node, there are vessels that bring in stuff, right? You have what's called your lymphatics, right? So afferent lymphatics, and you also have an efferent lymphatic, right? So that means that outside of these nodes, right, if I was to screw up this picture, there's a network, there's a connection, right, of lymphatics going around, okay? So those are your lymphatic vessels, okay? And lymphatics ultimately drain into the blood. Remember that. Your lymph vessels or your lymphatics, okay, ultimately they drain into your blood. That's the connection. That is how lymph and blood connect, okay? So that's how something that's coming out of the lymph nodes can actually get into the blood. Now, when it comes to your main lymphatic vessels, there are two of them, okay, that you need to know. There is what's called your thoracic duct, and you also have your right lymphatic duct, all right? So your thoracic duct is just your left lymphatic duct. They just didn't want to give it the name left, but is your left lymphatic duct, okay? Whereas your right lymphatic duct is just right lymphatic duct. So all of the lymph, right? Now here is also what happens. I was about to say all of the lymph from the right side drains into right lymphatic duct, but not really. The right only takes your right upper extremity and above. That's what is shaded in this picture. So this shaded region here represents your right lymphatic duct distribution, okay? And then all these other lymph nodes, all of these, both left and right, will drain into your left lymphatic duct. So the rest of the body is left lymphatic duct. So for example, if the question is talking about, like maybe, let's trace it back. A patient has cellulitis, right, of their foot, right? Maybe because maybe they had some fungal infection that caused some webs between their toes, right? And those webs or fissures became cracks and bacteria got into the person's legs and now they have cellulitis, right? Ultimately, what lymphatic duct is it going to drain into? And let's assume it says this whole thing started off in the right leg, okay? Do not be quick to say, well, right leg, right lymphatic duct. No, because right leg is below the diaphragm. So remember, below the diaphragm, everything goes to the left. There's going to be a crossover somewhere midline, right, where everything crosses over to the left and goes into your thoracic duct, okay? So left leg, left inguinal, right inguinal, right? Everything in this region goes into your thoracic duct. Now, I also said that they drain into the blood. How exactly do they drain into the blood? They drain in at what's called your venous angle on the left and the right, okay? And if you have the time, look up pictures of this. Right there on the angle between your neck and your shoulder is where your lymphatics enter into your blood, okay? And that's called your venous angle, okay? And you must know the veins that make up your venous angle. Let me see if it actually says it here. Well, yeah, there it is. Your subclavian vein and your internal jugular vein. So what happens is, this is your venous angle, right? You have your internal jugular vein, I call that your IJV, and then you have your subclavian vein, I call it SCV, right? Obviously, this angle that they make is called your venous angle. And what happens is your lymphatic ducts pierce in right there, and that's how lymphatics get into the blood, right? So if this, let me make another sketch on this side. Okay, and I'm also going to have lymphatics entering right there. Okay, so if this was patient looking at me, all right, so that's going to be their right and that's going to be the left. So obviously on the left side, it is going to be called what? Let me remove this right here. So don't forget that's your venous angle. Okay, just remember. Okay, so on the left side is going to be called what? My thoracic duct. Okay, and on the right side is going to be called my right lymphatic duct. Okay. All right, so that's the summary of that. So go over the rest of these, but like I said, as you go through, once you get into the systems, right, then start connecting these dots. So if you're doing cardio, look at, okay, what are the lymph nodes I have in this area? Which ones are superficial? Which ones are deep? Okay. And when can they be affected? If you're looking at what's called pulmonary, then okay, if a patient has pneumonia or TB or something like sarcoidosis, which lymph nodes could this drain into, right? So when you set into the systems, don't forget about this, link it together as well. So let's move on to the spleen, all right? Now, primary organ and secondary organ, definitely a secondary lymphoid organ, right? Not primary, because the primary is the bone marrow, all right? And the thymus. So just like your lymph node, all right, this is a secondary organ. So we're going to see similarities here, all right? It's going to be similarities. Now, the difference is, here is one difference. Your spleen does not have lymphatics. So unlike your lymph node, we don't have afferent lymphatic vessels coming in. No, spleen is a nice smooth organ, right? What comes in is blood, what goes out is blood. There's no lymphatics here, okay? However, we have immune cells in the spleen. Okay, and we know where the spleen is located, obviously, right? In your abdomen, right? Your left upper quadrant on the opposite side, right? The liver on the right, spleen on the left. All right. So it's a secondary lymphoid organ, all right? And we know that your secondary lymphoid organs have one job, all right? And that job is pretty much to allow interaction, okay? And for interaction to occur, all right, it means that I need to have B cells and T cells and all that kind of stuff, right? So just the same way you study lymph node with the spleen, you need to figure out, where do I have my B cells? Where do I have my T cells? So let's go find it. When you look in here, right, there's an area of the spleen called your white pulp. Let's start from there. Your white pulp is white, which means white blood cells. And what are your white blood cells? Your leukocytes. Those are your B cells and your T cells, okay? So in here is where I'm gonna have my B cells and T cells. They're in the same region called the white pulp, okay? But when you look inside of that white pulp, do you notice something that looks like something we saw in the lymph node? Yes. That's another follicle right there. When you think of follicles, especially if there's a germinal center, do you see the similarities? Germinal center tells me that that is my B cell action right there. What else do we see that we saw before? Guess what? It's a mantle zone as well. So there's going to be transitional B lymphocytes in that mantle zone. Okay, so the mantle zone. And then what's also unique about this is they have also what's called a marginal zone, which is outside of the mantle zone. Okay, so there's a marginal zone as well, but that's for your B cells. Okay, now the thing about it is, what about your T cells? Okay, where are you going to find your T cells? Okay, your T cells are located between what's called your PALS, right? PALS, which stands for your periarterial lymphatic sheath. Okay, and it's part of your white pulp, but surrounding the B cell area. Okay, so that's it. But now we also have what's called the red pulp. All right, we also have what's called the red pulp, which we didn't see in the lymph nodes. So this tells us something new here as well. If we have a red pulp, then it means that we're dealing with red blood cells. So this should remind you that your spleen has two functions, okay? Your spleen is both, if I was to put this into two systems, the spleen has immunologic functions and it has hematologic functions, all right? And that's why when we go to hematology and oncology, we're gonna talk about the spleen again, right? Why? Because of this red pulp. There's some red blood cell activity going on in the spleen, okay? And what exactly is that? It's actually red blood cell destruction. That's really what it is. Your spleen carries out red blood cell destruction, and it uses what's called your reticuloendothelial system. Let me see if I can squeeze it in somewhere. Okay. So your actually, let me put it right here because I see where they say reticular fibrous network. Reticular fibrous network usually comes out to give us what's called your reticuloendothelial system, your RES. Simply put, your RES is your system for red blood cell destruction. Because remember, your red blood cells only have a lifespan of 120 days. They don't live forever. They have to be destroyed, right? In a very nice and clean way. Who's going to do that? It's the spleen. So all the old red blood cells come in here to get destroyed. That's why we have a red pulp, okay? Now, so we all go through this, everybody. However, you run into trouble if you have excessive red blood cell destruction, right? So if you get a random question about excessive activity of your reticular endothelial system, then you know that this person is obviously going to have some kind of hemolytic anemia, because what this red system does is it destroys red blood cells. Then you link it as well to jaundice, because we know that when we break down red blood cells, we're going to release bilirubin, right? And jaundice can set in, Okay. So remember that part as well. Let's see what else about the spleen. Okay. Is yeah. So outside of normal destruction, your spleen also does not like abnormal red blood cells. And we'll talk about this in hematology again. It doesn't like abnormal red blood cells. If the red blood cell looks weird, classic example, sickle cell, the spleen is going to destroy it. Okay. So, however, the problem with sickle cell is when the spleen goes on destroying red blood cells, it's working over time, so it burns out. That's what you call the autosplenectomy, all right? And that pretty much means that your spleen has burnt out because it's been working over time, trying to destroy red blood cells that look sickled, all right? Which contributes, that's the reason why sickle cell is a hemolytic anemia, all right? But ultimately, when your spleen burns out, then now we lose other activities that the spleen does, right? Another function of your spleen is actually protection from infections, okay? Protection from infections, right? Especially what's considered to be your encapsulated organisms, right? This is high yield, right? And what are your encapsulated organisms, right? This is what I like to call the sheen organisms, right? And sheen just means your strep pneumo, Haemophilus influenzae, and your Neisseria meningitidis, right? So your meningococcus. So when you lose your spleen, you lose protection against the sheen. Sheen is strep pneumo, Haemophilus influenzae, and type B, and Neisseria. Okay. So you could get a question talking about a patient that is undergoing splenectomy, all right, surgically, or a patient who has sickle cell and is about to or has undergone autosplenectomy, right? Is there any vaccination that these patients need to get? Yes, they need to be vaccinated against the sheen organisms, because when you lose your spleen, you become prone to this, okay? There are other findings that you can also see in people who have lost their spleen, either intentionally with surgery or unintentionally, all right? And all of these, this is hematology right here. So all of this will touch on it again in hematology. You can see target cells, okay? You can see your humoral jelly bodies, all right, which are nuclear remnants, because the spleen is responsible for removing the nuclear remnants from red blood cells. So if you lose your spleen, you don't do that anymore, right? And also thrombocytosis can occur because that's part of the functions of the spleen, right, is to sequester these platelets, right? And also loss of sequestration of your lymphocytes as well. So these are things you can see post-splenectomy. So when you think about the spleen, you can see that it's a very important organ, right? It has immunological functions, hematological functions, infectious disease functions, name it. It does, everything, which is quite important, okay? All right. And actually, yeah, I should also mention this, okay? Your reticular endothelial system, okay, the entire system involves macrophages as well. I almost forgot that, okay? And those macrophages can be found in your marginal zone, okay? So don't forget, we're going to see it again in hematology. You have splenic macrophages, and they're responsible for a lot of destruction that goes on in the spleen, okay? So those are our two most important secondary lymphoid organs, right? So coming over to the primary, right? With the primary, you have the thymus, okay? So we know where the thymus is located, in the mediastinum, right? Just as a refresher for anyone who may not remember, what is your mediastinum, right? Your mediastinum is pretty much just the space between your lungs, period. That's it. Mediastinum, remember, is the space between your lungs. So anything in between your lungs, it's in the mediastinum. So your heart, mediastinum, right? Your bronchis, mediastinum. Your esophagus, mediastinum. Anything in the middle of your lungs is in the mediastinum, right? So guess what? One of the structures in there is going to be your thymus, okay? So your thymus is also in the mediastinum. Remember that. It is not in the neck, it's in the chest. Okay, very close to the heart. The thymus is in the chest, very close to the heart. Now, in adults, you don't see it because it involutes, but if you want to get a clear view at the thymus, then do an X-ray on a child. Okay. So, and also always differentiate this. I know sometimes people get confused between that and the thyroid. Thyroid is in the neck, right? I always think of the thyroid as a bow tie, all right? And you don't put a bow tie on your chest, you wear it in your neck. So your thyroid is in the neck, the thymus is in the chest, okay? So B&T cells, we know, are made in the bone marrow, but the T in thymus is for T cells. The T is for T cells, okay? Because this is where your T cells differentiate and mature. That is the job of your thymus. If you had one job, it's for T cell maturation and differentiation. All right, B cells do all of that in the bone marrow. They don't leave. Okay. So in terms of embryology, what is the thymus derived from? These are bullet points you have to remember. Your thymus comes from your third pharyngeal pouch. All right, from your third pharyngeal pouch. Yeah, if I remember correctly, the third pharyngeal pouch it's coming from the ventral wing. All right, let me write this here. Your third pharyngeal pouch, you have the ventral wing that gives you the thymus, and then you have the dorsal wing that gives you the inferior parathyroids. Okay, and the superior parathyroids would come from your fourth pharyngeal pouch, by the way. Okay, so your fourth pharyngeal pouch will give you your superior parathyroids. Okay, so why is this important? It's important because this should remind you that if I'm losing thymus, who can I lose at the same time? I may lose some parathyroids too. Okay, if I lose thymus, parathyroids may go at the same time because they come from the same place, right? This is why in the judges, you have calcium problems too. Okay, you have calcium problems. So in the judges, we know we lose thymus, but we get calcium problems because we can lose some parathyroids and they come from the same mom right there. Okay. And also just random, just in case I probably may never get the chance to go over this, but don't forget that all of these is your pharyngeal apparatus, right? And just as a quick side note, this is not immunology, but it doesn't hurt. Your pharyngeal apparatus, all right, always has three parts. You have the clefts, you have the arches, and you have the pouches. Okay, the clefts are on the outside, so they're going to be ectoderm. The arches are in the middle, so they're going to be mesoderm. And the pouches are on the inside, so they're going to be endoderm. So if I talk about the thymus, right, then you must make the connection that the thymus is derived from endoderm. So first aid sneaks it in right there, but there's more to that story. This is a story right here, right? And these are the little like things, details that may show up in questions that are important. So if you remember that clefts are ectoderm, arches are mesoderm, and pouches are endoderm, then any structure that comes from a pouch is an endoderm. And that includes your thymus and your parathyroids because they come from the third pharyngeal pouch. Okay, so remember that. Okay, the endoderm. But the lymphocytes, right? The lymphocytes, the actual cells that we see inside of the thymus, are actually going to be from mesoderm. Remember that. The thymus itself, endoderm. But the cells on the inside, right, is going to be your mesoderm. Okay. And just like your lymph node and your spleen, right, the thymus as well is going to have a cortex, is going to have a medulla. Okay. The cortex is where we're going to have the T cells, all right, that are mature. And the medulla is going to have what's it called? Your cortex is going to have your immature, because you always start from the outside and go inside. So immature on the outside, right? And then you drain to the center before you leave, and you get your mature T cells, right? In the center, okay? And then in terms of your shape, your thymus typically has what's called a shape like a sail, right? So it's usually described as a sail sign on chest X-ray, okay? So unimportant things to remember, these are just associations that come from a whole bunch of questions. And I like how they've listed them all here. Is now, obviously, we know that the thymus kind of disappears as you get older, right? By age 3, almost disappears. You can't really see it, but it's there. So, however, you get a question about a 6 or 7, it's 8 months old newborn, right? Even a 1-year-old infant. And on chest X-ray, we cannot find the cell. They may describe it, or they may just give you the X-ray, and you got to remember that, okay, this is a 6-month-old. I should see that cell. You're still young. I need to see your thymus in your X-ray. But then we don't, right? That means that this is a child that is experiencing, right, either a hypoplastic thymus or an absent thymic shadow. It means your thymus is either so small for your age, or it's missing. Then you have to think about what are the scenarios that can make it go missing. Bring it back to your third pharyngeal pouch. Your third pharyngeal pouch has not developed DiGeorge syndrome, right? So then you're looking out for other symptoms like parathyroid did not show up, okay? So you can have calcium derangement there. Or it could be an immunodeficiency like your SCID, your severe combined immunodeficiency, right? Where you have a clonal deletion of both B and T cells. That could actually, on the T cell side, your thymus may just be missing or very, very small because you didn't even have the T cells coming in from the bone marrow to get mature, okay? So that's on one side. On the other side, the thymus can actually get bigger. When that happens, right, so this is small missing thymus. On this other side, big thymus, thymoma. Obviously, it's a tumor, right? Now, it's not causative, it's just an association, right? They've listed a whole bunch of stuff here, but if there's one that I'll say go home with this, it's myasthenia gravis. Remember that. I've seen lots of questions on this. If you do enough UWorld questions, you'll see a couple on this. I can guarantee that. You have to remember that for some weird reason, patients that have myasthenia gravis tend to also have a thymoma going on. Okay, so if you want to talk about things to memorize, that's definitely one of them to add to your notes, okay? All right. So moving on to the types of immunity, right? Your innate versus your adaptive, right? Innate versus adaptive immunity, right? Now, your innate immunity is your immediate immunity. That's how I can think about it, is you just got exposed to something. Your body doesn't know what it is, but it's going to try to fight it. That's innate, okay? Adaptive is, I've seen you before, and you're not going to get away with it this time. That's adaptive. That's the difference, okay? So obviously, your innate immunity, right, is non-specific. Let's talk about the keywords here, all right? It is non-specific and it's rapid because it is just, you just got exposed. It doesn't matter if you've seen it or not before. Can the body do anything to just try to fight this right now? Minutes to hours, immediate, all right? That's your innate immunity right there. So what are the components of your innate immunity? Your neutrophils. So a lot of times things happen and we have no idea, right? The reason why a lot of times we don't get sick is because your innate immune system is working, right? So you get exposed to a whole bunch of stuff every day, but you have no clue about it because you have a functioning innate immune system that does all the fighting for you, and you have no clue, all right? Your neutrophils, your macrophages, your monocytes, your dendritic cells, your natural killer cells, the only lymphocyte member of this group. All right, and we'll talk about that again shortly, but they're the odd ones in this group, but the innate immune system as well. Okay, it complements, and even just things like physical epithelial barriers, right? Not even cells, just barriers. It prevent you from getting infected with things. That's your innate immune system. Okay, so that's the main summary there. Now on the flip side, your adaptive immune system is where we have our cellular and humoral immunity. Okay, so in adaptive, right, we have cellular and humoral. And cellular just means cells, right? Your lymphocytes, B cells, T cells. Now, humoral means, yeah, now we're going to use the antibodies. Okay, so I should have actually written it the other way. So this one is humoral. And this right here is your cellular, right? So that's adaptive. The key thing about adaptive is the main word here is memory. Adaptive is where that's it right there. That's where you have memory, all right? Your vaccines and stuff is all about adaptive immunity. The concept is you get exposed to an antigen, the body recognizes it, right? Or kind of makes a memory of it and prepares for the event that if this were to ever come back the second time around, I will be more prepared. That is what the adaptive immunity is, right? So you're going to see things like a VDJ recombination, right? And all that. But the goal is we're going to make memory cells, B and T cells, that would help you mount a better, stronger immune response the second time around, all right? And that's the whole concept of vaccines, really, right? It's to build a strong adaptive immune system, right? So they'll come back. And then your MHCs, right? There's MHC1 and MHC2, okay? Some tiny details here and there about them, okay? But I'll just focus on some areas and you guys read up on the rest. What are the main areas? MHC1 always goes with CD8. Now, there always has to be a T-cell receptor, so that's nothing unique, okay? MHC1 goes with CD8, MHC2 goes with CD4. In terms of structure, MHC1 is called 1 because it has one long chain and one short chain, as you can see. You have a long chain and you have a short chain, okay? Now, at the end of the day, your MHCs, right? These are like proteins. These are proteins, these are proteinous structures. So they have to be coded for by genes, because take it back to biochemistry. What's the central dogma of molecular biology is that everything starts off with what? DNA, and then it goes to RNA, and RNA goes to proteins, and proteins give you function, okay? And now DNA, we know, can recycle itself. So I can make DNA from more DNA. When that happens, we call it what? Replication. Okay. When DNA changes to RNA, we call that transcription. And when RNA helps us make proteins, we call that translation. Okay. And don't forget, what's DNA? Your DNA is your genes. All right. Your DNA is your gene segments. Okay. So what they're trying to tell us is that your MHC complexes 1 and 2, right? These are like proteins, but the genes that code them, the DNA side of things, is HLA genes. Okay, so that's what you're talking about, the loci, which HLAs give you 1 and which HLAs give you 2, right? Easy way to remember this is the ones that give you 1 have 1 letter, all right? It's as simple as A, B, C, 1 letter. Okay, if it has two letters, then it gives you MHC2. So HLA is the gene, MHC2 is the end result that will give you a specific function. And that function, most of the times, involves antigen presentation. Okay. So, so what do they express? All right, what's the expression here? All right. So MHC2 is for your antigen presenting cells, all right? Your MHC1 key point here is for all nucleated cells, right? Antigen presenting cells as well, and platelets, except your red blood cells. Okay, so your MHC1 is present in more things than your MHC2. Okay, and now here's the most important part, the function, right? So follow me closely on this because these words mean a lot. Your MHC1 is for endogenous antigens. Endogenous means they're from the inside, they're endogens, they're from the inside. These are antigens from inside of the cell. Okay, so these are either antigens that have been made by viruses, okay, or proteins on the inside of the cell, which is what viruses do. Because remember, one difference between bacteria and viruses is that the way viruses work, they actually, I always picture this as they're like alien ships, right? And then they land on the cell, right? So if this was a cell, what the virus would do is it would land like an alien spaceship, okay? And it will attach itself like that. Doesn't get into the cell. But then what it will do is it will inject its genetic material into the cell, right? It's like an alien attack, all right? So once it does that, then this antigen comes into the cell and hijacks the cell's mechanisms. And it tells the cell, hey, I need your mitochondria, I need your rough ER, I need all your organelles. So it will stop the cell from making what it normally does, and it enslaves the cell to make more of its genetic material, right? And more of its proteins. So the virus now begins to replicate on the inside of this cell, right? By using the cell's tools. So you hijack the store, you use the tools, and you make more of yourself. So because of that, viral antigens are considered endogenous because the ones you're seeing inside here were made inside. They didn't come from the outside, right? The one that was outside only infected the cell by sending in this strand of genetic material, but the new viruses are made inside. So anytime going forward, whenever you see the term endogenous antigens, it's viruses, okay? So you can see that MHC1 really likes to take care of your viruses, okay? And since we know that MHC1 goes with CD8, right? It goes with CD8. And easy way to remember this is that the product has to be 8, right? So here you have 1 times 8 will give you 8. So that's good. Here 2 times 4 has to give you 8. So that's good. So that's why MHC2 goes with CD4, MHC1, CD8, 1 and 8, 2 and 4. Okay. So that also reminds you that your CD8 cytotoxic T cells will be effective against viruses. So going forward, when we talk about viruses, we know what kind of cells we need to fight them, okay? Now, on the flip side, when you look at your MHC2 is actually for exogenous antigens, which is bacteria, okay? Because what happens is bacteria actually gets endocytosed into the cell, okay? So the bacterial antigens you see on the inside of the cell, so it starts like this, you have the bacteria, okay? And then it finds the cell, okay? And then what happens is eventually the bacteria is inside of the cell, okay? Where endocytosis. So that's why those would be considered exogenous antigens or exogenous proteins because they came from the outside. Okay, so that will go to your CD4 cells, all right? And just in terms of antigen loading, right? This we've talked about this indirectly, but you can make the connection, right? For antigen loading, it says your antigen peptides are loaded onto your MHC1 in the rough ER. What is the rough ER? It's a cell organelle, right? Because the viruses have taken over the cell's internal mechanisms, including the rough ER. So now this antigen peptides, right, will be loaded to your MHC1 in your rough ER, right? After delivery via what's called your TAP, okay? But on this other side, we have to use what's called an endosome. Why? Because endocytosis is taking place, like we just said. That is how an exogenous antigen gets into the cell, is by what? Endocytosis, okay? So that's how the antigen is loaded following the release of something called your invariant chain. Remember this, your invariant chain is specific to your MHC2, okay? And that's it right there. So this table right here just gives you your HLA subtypes associated with certain diseases, okay? All right, so this you have to memorize them, like your B27, all right? It's your pair. So I always use the mnemonic a pair of B27 shoes. That's the mnemonic that I use to remind me that the pair is psoriatic arthritis and ankylosing spondylitis, your IBD, associated arthritis and reactive arthritis. Come up with whatever mnemonic works for you, but just remember that's your B27, right? And they have a bunch of other ones there. So this pretty much just memorize this table, right? And as you go through the system, some of these will pop up again. And when they do, just try to commit them to memory as much as you can.
I have a question.
Yeah.
I'm actually working off, I'm working off of an older book, and it's got a bunch of different HLA subtypes. So it has listed A3, B8. Do you know why they would take some out and leave some in for different years?
I
Yeah.
have no idea. B8, isn't that for Graves' disease or something like that?
B as in boy 8 is Addison and myasthenia gravis.
Okay, is there one for Graves' disease there? Because I thought there used to be one for Graves' disease.
Yeah, that's DR3.
DR3. Oh, okay, actually it's still here. Yeah, I
but
don't
like
know.
DR2, which is pretty, it's multiple sclerosis, good pasture syndrome, systemic lupus, and it's not listed on the one that you're showing, which was weird.
Right. So I mean, I have no idea why they'll take it out. The safest bet is have a comprehensive list, right? Even if you've taken it out, still study it just in case. My guess is they've probably taken it out maybe because it's not showing up in questions and they're trying to narrow it down to the ones that are high yield. That would be my guess. But
interesting. Okay.
The safe bet to be, if it's been taken out, just double check. If it's actually correct, then add it to your list. Don't ignore it.
Right, exactly. Okay, thank you.
All right, no problem. All right, so let's talk about natural killer cells. A very unique kind of cells here, okay? Here are the highlights. Your natural killer cells are lymphocytes. Remember that, okay? So they are just like a B and T cells. But to be even more specific, your natural killer cells remind me of CD8 lymphocytes, your cytotoxic T cells. Okay, but remember, they're not CD8. They just look like CD8 and behave like CD8. The difference is they are in your innate immune system, whereas your CD8 cells are adaptive. Okay, but other than that, they're very similar and they actually kill the same kind of cells. Okay, so if you're seeing, well, let's go straight to it. The two types of cells that they like to kill is your virus infected cells, which we've already talked about. It says CD8 is for viruses, but then the other one is tumor cells, cancer infected cells. So viral cells and cancer cells, or just tumor cells, are the two types of cells that CD8 likes to take care of. And those are the same kind of cells that your natural killer cells like to take care of as well. Okay, so the difference just becomes, do I want to take care of this viral cell in my innate immune system? Then I use a natural killer cell. But I want to take care of this virus in an adaptive way. Then I use my CD8. Now, how do you differentiate it in the question, right? If the question uses the word unspecific or non-specific, right? You've been exposed to a non-specific virus, right? Or a virus that the body does not recognize, and you want to mount an immediate immune response. Which cell are you going to use? Are you going to use a CD8 cell or natural killer cell? The answer is you're going to use a natural killer cell. Okay. Now, if the body recognizes this virus and says, I've seen you before, I know you, right? Then that's when the CD8 comes in, because the adaptive will mount a better immune response. That's really the difference between them. So it actually says it right here, right? This is induced to kill when exposed to a non-specific, that's the key word. It has to be a non-specific activation signal on a target cell, okay? So that's one part of it, and that's the more important part. But then also it could be when it's exposed to a cell that has an absence, right, of MHT1 on a target cell surface, okay? That's the other scenario. So how does it do its killing? It uses what's called your perforin and granzymes, all right? Perforin and granzymes to destroy the cell. The perforin, like the name implies, perforates the cell, perforates the virus, all right? So the perforin perforates it, and then the granzymes brings the enzymes that induce apoptosis of the cell, and that's pretty much how you destroy it, okay? So remember that. And then in terms of activation, right, it's activated by your interferons, right, alpha and beta, right, and your interleukins 2 and 12. So easy to remember this one, 2, 12, alpha and beta, okay. And then also, the other thing to remember about this is the CDs, the cluster differentiation markers. The CD markers for natural killer cells are CD16 and CD56. Okay, so CD16 and CD56 will be the CD markers for your natural killer cells. And then the last thing to remember here is the mechanism. So we've seen exactly how it does the perforin and granzymes, but what's the unique process there, right? That unique process is something called your ADCC, right? You do enough questions, you're definitely going to come across this, your ADCC, right? That's another way to kill. And what does ADCC mean? It's right there. It's your antibody-dependent cell-mediated cytotoxicity, all right? Antibody-dependent cell-mediated cytotoxicity. Let's talk about that real quick, okay? So it's antibody dependent, which means there has to be an antibody, right? Okay, so what's the antibody? This is how you remember it. What's the antibody we're talking about? So the antibody dependent, that antibody is your IgG. Okay, that's your IgG, all right? And then the cell mediated, right? What is cell mediated? Cell mediated means lymphocytes. Wherever you see cell mediated, it means what? Lymphocytes, all right? So what is the lymphocyte here? The lymphocyte is a natural killer cell, because remember, your B and T cells are not the only lymphocytes, right? Your natural killer cell is a lymphocyte as well. So what we're saying is that there is some kind of reaction where an antibody can actually induce a natural killer cell to go and kill, all right? So let me write it here again. The antibody dependent, the antibody right here is your IgG, all right? And the cell mediated is your NK cell. And when these two come together, when they come together, that antibody would stimulate the natural killer cell to go and kill, all right? So that's called your ADCC. So how does it happen? Is the natural killer cell has to come, right, and actually binds to the FC region of that IgG antibody, all right? But what part of the natural killer cell is binding? It's your CD16. Don't forget I said the CD markers for your natural killer cells is your CD16 and your CD56. So when that CD16 of your NK cell binds to the FC portion of the IgG, then it tells natural killer cell, go ahead and destroy all these viruses. We don't like them. And that's it. Okay. So remember that that's a mechanism right there. So then let's move on to the other lymphocyte family members, and that's your B and T cells. So don't forget, when you're studying this page, 1, 2, and 3 are all lymphocytes. NK cells, B cells, T cells, they're all lymphocytes. The difference is NK cells, innate immune system, but B and T cells is adaptive. Okay, of which in the adaptive, we can now also have your humoral, which has to do with antibodies coming from the B cells, and then you have your cell-mediated, which is mainly the T cells. Okay, so what's the job of your B cells? We've seen them already in your lymph nodes and your spleen. We've seen the functions that they bring, okay? Even on spleen, but obviously your B cells mainly, right? Their main job is to make antibodies, okay? So one of the main functions of the B cells is to make antibodies, and that action would happen by differentiating into plasma cells first, all right? Remember, plasma cells that have the clock face chromatin, okay? And then the plasma cells to differentiate into your specific antibodies. We'll touch on that if time permits. Okay, so that's one function. Your B cells are also required, right, to recognize and present antigens. So your B cells can function as antigen presenting cells. All right, we're going to talk on that very, very soon when we go to antigen presentation. All right, but then also finally, because it's part of your adaptive immune system, it needs memory. Okay, so it maintains immunological memory that will allow you to respond to antigens in the future. When you get new antigen in the future, then the body can say, I recognize you, and I want to go ahead and do some damage. All right. So that's pretty much, and we'll touch on these in detail. This is just an introduction. Now your T cells on the other side, like I said, you can have your CD4, you can have your CD8, right? Your CD8 is your cytotoxic T cell that we know likes two types of cells, right? Your virus-infected cells and your tumor cells. Do you see the resemblance? It's the exact same kind of cells that our natural killer cells like to destroy. Look at it. Virus-infected cells and tumor cells. That's the reason why I said your natural killer cells are just like a replica of your CD8 cell. The difference is natural killer cell is in your innate immune system. This one is in your adaptive. And look at how does it kill. Uses the exact same things, perforin and granzymes, right? Perforin to make holes in the cell, granzymes are the enzymes, right, that will carry out the apoptosis and destroy the cell. Exactly the same thing natural killer cells do. The difference is when it's doing this, right, it is responding to a specific signal. Right? Specific signal means it recognizes the virus that it's trying to deal with. Okay. Whereas here, it's non-specific. Okay. So that's the main thing about your T cells right there. So let's proceed. It's about to get even more interesting. Okay. So let's talk about your differentiation, right, of your T cells. All right. I hope all of this is making sense and it's coming together for you guys. But this is just like, even if we don't cover all of this, this is, I always say this, the way I teach is how I recommend people study is go through the details like this and just put it together and do questions. And you get better from there. Okay. So with your T cells, we've seen that they have your T cells are immune cells, so they have to be made in the primary organ, right? A primary lymphoid organ. And what are your primary lymphoid organs? Your bone marrow and your thymus, primary. And then we said the secondary was what? The secondary was the lymph node and the spleen. Okay. We said the job of the primary is production, right? The secondary is just for proliferation, right? And also for interaction if we've been, if there's a specific antigen that we need to take care of, all right? So put all of that together right here. Now, when it comes to your T cell production and differentiation, the main production starts off in the bone marrow. And that's where you have your T cell precursor. Okay. So your T cell precursor starts right there. And then by the time we get to the thymus, right, we're going to have what's called your positive and negative selection. Now, remember, the thymus is the site of T cell maturation. Okay. The bone marrow is T cell production. All right. T cell production, bone marrow, T cell maturation, and thymus. So what is in that maturation? The maturation is the positive and the negative selection. So let's go through each one. What is positive selection? Okay. The initial T cells that are made are called naive T cells. Okay. So they're called naive T cells. They don't know what they want to be when they grow up, right? But they want to be T cells. Okay, so remember that the initial cell, right, is going to be your naive T cell. So your naive T cell it's in the thymus, right? And even by the time we're done with the positive and negative selection, right, the T cells are still going to be considered naive, all right, because they haven't decided, okay, which exact kind of T cell am I going to be? Okay. So, but really what we have here is we have a precursor T cell that is both CD4 and CD8, right? But very importantly, it has a T cell receptor. So that's your CD8, CD4, and T cell. The key thing here is, remember, is there's a T cell receptor present. Okay. Now, why is that important? All right. What this is telling us is that, first of all, we want to make a T cell that we know should be able to bind an MHC. And like you've seen here, right, when we talked about MHCs, to bind MHCs, you need what? You need a T cell receptor for starters, and either a CD8 and a CD4, or a CD4, okay? So those are the three things you need for binding, right? The three things you need for MHC binding is, number one, there must be a T cell receptor. And number two, you need a CD4 or CD8. So what happens in the thymus is, when I start making T cells, I need to make sure that, first of all, these T cells have, number one, a T cell receptor, and they have either a CD4 or CD8 or both. If they don't meet this criteria, delete. That is your positive selection. Okay, that is your positive selection. Positive selection removes cells, right, that don't have the T cell receptor or CD4, CD8, because it means that these are cells that cannot bind MHC. Okay, so if the T cell shows up here and says, hey, I have the ability to bind MHC because I have a receptor and I have CD4, CD8, then it stays. The rest of them gone. Right? So that's step one. Now, step two is going to be a negative selection. Okay. So in negative selection, this is actually when there's now a differentiation, a clear differentiation into, okay, now I'm either going to be a CD8 cell, right? Or I'm going to be a CD4 cell. Okay. And this is happening in the medulla. So remember this. The positive selection is happening in the cortex. All right, so we're starting out, and then in the medulla is a negative selection, so we're coming inwards. Now, other than differentiating to that, the most important thing here is that we want to remove T cells that are going to destroy us, okay? Because you can make a lot of T cells that are active, but end up destroying your own cells, and now you have a bunch of autoimmune disorders, okay? So this is when T cells that have the affinity, the word typically uses self-antigens. Self-antigens are your own proteins, which really don't need to be attacked all the time. If the T cells have a high affinity for your own proteins, your self-antigens, then they get destroyed, okay? They get destroyed, or they become regulatory T cells, okay? So that is where the Treg cells are born. Okay. And what's the goal here is we don't want T cells that can attack us, because when we attack ourselves, what do we call that? That is autoimmunity. And that's why if you look at the notes, it will tell you that your Treg cells help you do what? Prevent autoimmunity. Because by converting to them, we're preventing ourselves from being making T cells that can destroy us. So when you look at your Treg cells, what you want to remember is that these are cells that could have destroyed you. But now the body said, no, rather than destroy you, we're going to put in a dormant state of a Treg cell, all right, to maintain some kind of tolerance. Yeah. Now, and some of them won't even get it. Some of them are just going to get deleted completely. You get a clonal deletion. So that's going to be your negative selection. Okay. So the question somebody may be wondering is, all of this is happening in the thymus. How does the thymus even know that this T cell has a potential to attack something in the body, right? It's almost like you go somewhere, and they're like, there's going to be some food coming. This food may taste good. It may not taste good, all right? But we can give you a sample, right? Like, here's some toothpick. Here's a sample. If you like this chicken, you can get more. That is exactly what happens in the thymus. Obviously, the thymus is a small organ. It's not the whole body, okay? But there are a few self-antigens that are kept in the thymus for testing purposes, so that the body can use that to test and see if these T cells can attack you, okay? So those are what you call your tissue-restricted self-antigens, right? That are expressed in the thymus, right, through the use of your AIRE, all right, which is your autoimmune regulator. Okay, so your autoimmune regulator allows you to express some self-antigens in the thymus, and you need this, right? Because this is your sample, right? So look at it this way. That's easy to remember. This is your body sample to test, all right? So guess what happens if you don't have the sample? Now you could go buy this dish that you never tasted, and now you don't like it and you spit it out, okay? So that is the reason why when we don't have that sample, a deficiency of the sample, the AIR, right? Your autoimmune regulator can lead to autoimmune polyendocrine syndrome, right? Where you have a bunch, right, of autoimmune problems, right? More specifically, right, your chronic mucocutaneous candidiasis, right? Hypo-PTH, adrenal insufficiency, and just recurrent candida infection. So that's called the mnemonic. There's your chair, but come up with whatever helps you remember it. But the bottom line is, it is an autoimmune disorder. It is your autoimmune. It's called your autoimmune polyendocrine syndrome. You get a bunch of endocrine problems that are autoimmune because you did not have these sample cells, right? You didn't have these samples on the inside of your thymus. Okay.
Hey, doctor, I'm so sorry about that. Can I ask a question very quickly, please?
Sure. Yes, go ahead.
Excellent. Okay, so regarding the AIRE, so the reason that we're talking about it right here and the way that it applies to negative selection is that people that have this autoimmune polyendocrine syndrome type 1 have problems with negative selection.
Exactly.
Correct? Okay.
Exactly.
All right, cool.
That's a good way to put it, right?
Awesome.
So
thank you.
Just remember, your AIRE is just your sample for the entire meal.
Excellent.
Right? It is just for testing in your negative selection. And if you don't have it, then negative selection fails, and now you get autoimmune syndromes.
Awesome. Excellent. Thank you so much.
No problem. No problem. All right. So macrophage lymphocyte interaction, I think we'll talk about this eventually. Well, again, once we get to your macrophages and all that. But the reason why they've talked about it here is just to remind you, right, that your T helper 1 cells, your Th1 cells, I think is actually, yeah. So if you look at this, Yeah, this is what they're talking about here. All right, let's finish this picture. So after selection is done, obviously, then now we have clean, non-self-destructing cytotoxic T cell, which is my CD8, right? And that's easy. We know what this does, right? Its job is simple. It goes and it destroys virus cells and cancer cells, right? Done. The helper T cells is where it gets a little bit interesting, right? Because now the helper T cells, we can have different ones. Now, it could really be Th1 and Th2 are your main forms of this, okay? Th1 and Th2. However, there's Th17 that you cannot forget about, but the main ones are Th1 and Th2. So the H obviously means helper, all right? So T helper 1, T helper 2. So what it means to remember, your T helper 1 cell is induced by interferon gamma and interleukin 12. Okay. And once you get that Th1 cell, what it does is it actually secretes more interferon gamma and interleukin 2. All right. That interferon gamma is helpful in activating macrophages. Okay. In activating macrophages. And it also helps in activating your CD8 cells. So that's what you're talking about here in the macrophage lymphocyte interaction, is reminding you that you need some lymphocytes to activate macrophages, right? And the connection there is interferon gamma. Okay. So we'll come back to that. But on the other side, you could also have your T helper 2, all right, your Th2, all right, that can secrete your interleukin 4, 5, and 6, all right? And this kind of predominates in your allergic scenarios because it can increase IgE and activate eosinophils. Now, just I think we'll touch on this in hematology, but eosinophils, don't forget, is one of the markers that you tend to see in allergic reactions, but don't forget they're not the mediators of the reaction. They're more like, bystanders. The main mediators of your allergic reaction is going to be your histamine, what's it called, your mast cells and your basophils that release your histamine and all that. So even though we see eosinophils increasing there, you could see eosinophilia, right? I would consider them more like bystanders, but don't forget Th2 helps you get up there, all right? So between these two, if I really want to get some really strong action going, I'm going to use Th1 because it's bringing out the big guns, right? It's bringing out your macrophages and your cytotoxic T cells, okay? So remember that. But there is more to it, okay? There is more to it, and this is what we call your kind of like your co-signals, all right? Is, yes, we know Th1 and interferon gamma have that interaction where they can activate macrophages, but to actually carry out this function, right, it's actually enhanced by your CD40 ligand, right, and your CD40 interaction. Okay, so that's going to be one of those things that we're going to talk about very soon, especially when we talk about your B cell activation, is you're going to have all these ligand interactions. So you need to know that besides the main thing, what are the other signals that I need? And one of those signals is going to be your CD40 and your CD40 ligand, okay? Now, the CD40 ligand is usually on the helper T cell. That's the other part. The CD40 ligand is always in the helper T cell. The CD40 would be on the macrophage. And you're also going to see that when we move forward, you may also find CD40 on B cells as well, all right? Which would remind you that B cells sometimes can act like antigen-presenting cells, just like macrophages do, okay? So remember that. So when we get there, we'll repeat this again, but key thing here is your CD40 ligand is on your T cell, all right? Whatever helps you remember that, I don't know, but that's on your T cell, and then the CD40 is on the macrophages. In other scenarios, CD40 can be on the B cell, but the bottom line is, whenever I have a CD40 ligand and a CD40 interaction, it can help in some kind of activation of an immune response, okay? And then your cytotoxic T cells, right? I don't need to go over this, we've touched on it enough, all right? And then your Treg cells, all right? We said they help prevent all that autoimmunity, right? Your autoimmune syndrome and all that. Okay, so this is another one for the books to remember, your IPEX syndrome. Okay, you almost like if you go through UWorld, you're guaranteed to get at least a question or two on this from UWorld. Okay, so it's important to remember. So your IPEX obviously means your immune dysregulation, polyendocrinopathy, enteropathy, and your X-linked scenario. But the bottom line is, it's just like our autoimmune polyendocrine syndrome. The bottom line is, it's autoimmunity. That's what it's all about, right? Because you said the job of your Treg cells is to prevent autoimmunity. All right, they're the end results. They're part of the end results of your negative selection. Okay, so go through those and memorize what you need to. All right, so this is what I was talking about here: your T cell and your B cell activation. All right, you're going to see some things that we've seen already, like your CD40 and CD40 ligand. But let's start off with the T cell activation. Okay. Now, first things first, there has to be what's called the antigen presenting cells. Okay. There has to be what's called the antigen presenting cells. And your antigen presenting cells could be, like we just saw, it could be macrophages, which in that case, the macrophage has to come with its CD40. Okay. Your antigen presenting cells can be Langerhans cells, they can be dendritic cells, but very importantly, B cells can sometimes function as antigen presenting cells. Okay, and what antigen presenting cells do? They just bring the antigen. Okay, they bring the antigen, but guess where a lot of this is happening? It's happening in your lymph nodes, in your secondary organ, because this is where the interaction takes place. Interaction we talked about earlier, about your antigens and your immune cells coming together, right? This is it. All right, so an antigen presenting cell has to bring that antigen and present it. This is the reason why we need MHCs. So once again, it's going to come down to what kind of antigen am I presenting? Am I presenting an endogenous antigen, or am I presenting an exogenous antigen? And the rules remain the same. If it's an endogenous antigen, which could mean a virus, then I am going to use MHC1. Okay, so this could be virus. But if it's an exogenous antigen, which could mean bacteria, then I'm going to do what? I'm going to use MHC2. Okay, now, so that's just a general thing to remember. Now, in this scenario here, they only talk about one, but I want you to keep everything in perspective. So for example, when you look at this, it says your dendritic cell, in this case, is what's functioning as the antigen presenting cell. So you can flip this picture around and change it with the macrophage, with the Langerhans cell, with the B cell. Bottom line is, this is my antigen presenting cell on this given day. That's my APC right there. But without even saying much, when you look at the picture, I have an antigen that has been engulfed by this cell. That's phagocytosis. And phagocytosis is really endocytosis, right? And endocytosis means that I'm putting in an antigen that came from the outside. Okay, so off the bat in this picture, I know that what I'm seeing here is bacteria. It's not a virus, it's bacteria. Okay, because if it was a virus, then we shouldn't have any kind of endocytosis, right? We'll have the antigens will be made inside of the cell, but that's just what the details. The bottom line is the same thing happens. Once the antigen is in, the antigen is in. Now we just need to figure out what happens, all right? But I just want to remind you guys that the antigens can be different. They can be endogenous, they could be exogenous, okay? So really and truly in this picture, what they're showing you here is the possibilities. That's why they said MHC1 or 2, but really what we're using here is MHC2. because this is bacteria. So this is not really a picture of MHC1, but MHC2, which you can clearly see because it has two arms right there. All right. So don't get confused when you're studying this, right? The one they're just telling you that on another day, if it was a virus, it could be one. But really and truly, this picture is a picture of MHC2. Okay. Now, so we also said that for binding and recognition to occur, there has to be a T cell, right? And we said the T cell must have two things. Two things are required for binding. One, there must be a T cell receptor before we bind any MHC, right? And if it's MHC2, we must have CD4. If it's MHC1, we must have CD8. So let's check. Do we have a T cell receptor? Yes, we do. We've satisfied one of the criteria. And do we have a CD4, CD8? Yes, we do. So we have all we need for binding. All right. And what's going to happen now is the MHC will interact with the T cell receptor and the CD4 or CD8. Okay. And that's it. However, that's not all that's needed. All we've just described, right, is really what's called your signal one. All of this stuff right here, that is all just signal one. There has to be a signal two. Okay. Your signal two is also what's called your co-stimulatory signal, right? It's a second signal. It's not the first one, but you need it on the side as well. Okay. That's going to be signal two. And you must remember this. I'd love to ask you some questions. What exactly makes up my second signal? Okay. It is an interaction between B7 and CD28. The CD28 is coming from my T cell, but notice it calls it naive T cell, right? The B7, right, is going to come from the antigen presenting cell, and then the CD28 has to come from my T cell. All right. So look out for that in questions. Your co-stimulatory signal needs a B7 and CD28. Now, once those two come together as well, then now both signals are on and activation can happen full blown. Okay. This is how, we've been able to now use an antigen presenting cell to turn on that T cell. Okay. So now it depends on what kind of T cell is it. If it's a helper T cell, then it can produce cytokines, right? That can draw in other inflammatory or immune cells. Or if it's a cytotoxic T cell, then it's ready for the kill. It's like, where is the virus? Let's kill it. Let's get some perforin and granzymes and get this action going. Okay. So that just depends. So that's the process of your T cell activation. Doesn't matter if it's helper T cell or cytotoxic T cell. The bottom line is, number one, we need those requirements of your T cell receptor and the CD4, CD8 to bind with MHC1 or MHC2, right? And number two, you need the second signal. The second signal has to be a B7 and CD28. The CD28 coming from the T cell and the B7 coming from the antigen presenting cell. The way I like to remember this, what helps me, it may work for you, it may not, but come up with something is, because when I started studying initially, I used to mix this up. I used to get confused. Which one goes where? Does the B7 go with the T cell or the CD28, And I just say, you know what? It's a T cell. So it doesn't need any Bs. All right. B will go with B cell. So that's why I know CD28 goes with what? The T cell. All right. And then the B7 has to go with the antigen presenting cell, which we know sometimes our antigen presenting cell can be a B cell, but other times it's not. But it doesn't matter. If it's a B cell, you get B7. If it's a dendritic cell, no problem, B7. Langerhans cells, that's fine, B7. Macrophage, no problem, B7. Whatever kind of antigen presenting cell you are, bring your B7. All right. And then once you get the B7, we can walk in with CD28. All right. And you're good to go. All right. Now, what about your B cell activation and class switching? All right. Now, when it talks about class switching here, really talks about, it really goes into the antibodies. Because remember, your B cells differentiate into antibodies, right? Obviously going through plasma cells. And that's what class switching is all about, okay? Because the different antibodies you have, all right, I'm jumping ahead, but this will come in handy. The antibodies we have is your GAMED, right? Your antibodies are GAMED, GAMED, right? So that's your IgG, IgA, IgM, IgE, and IgD. Those are our antibodies, okay? What you must remember is that the antibodies we have by default, right, on your plasma cells is your M and your D. So always think about the degree you're trying to get, if you've already gotten it. It's your MD degree. That degree is what's present on your plasma cells, your MD, okay? So what that means is that if I need any other kind of antibody other than an M or a D, I have to switch to it, okay? And between the M and D, quite frankly, the D is just pretty much the most useless one. So we can just forget about it. So M is your mainstay. Your IgM is your mainstay antibody. So that means that on any day, if I need IgA, M has to switch to A. If something happens and I need IgG, my M has to switch to G. If some allergy is going on and I need IgE, my M has to switch to E. That's what you call the class switching. Okay, it's how do we go from the default, which is what? IgM, to anything else we need, which could be A, E, or G. Nobody cares about D. D does nothing. All right. So
I'm sorry, so that means, so then D does its class switch, is that what you mean?
yeah, because there are no, you only class switch is something that you need. All right. So there'll be no point of class switching to D because we don't really need it and it is already naturally present, right? So class switching is just going to be your GAE, right? How do we go from M to G, A, or E?
Got it.
All right. So, but that's down the road, all right? That's down the road. So let's talk about how did we even get to antibodies in the first place, all right? Let's talk about the B cell activation, because what we had on top was a T cell activation. And what you gathered out of this is that your T cells, all right? Let me summarize this here. If there's anything you get out of this, remember that your T cells, right, get activated by antigen presenting cells, which in some cases may actually be a B cell, because sometimes B cells are antigen presenting cells. But the bottom line is T cells get activated by antigen presenting cells. Okay. And really and truly is your helper T cell. Now, helper T cell can now activate a cytotoxic T cell, especially if it's a Th1 helper T cell, right? So now let's talk about B cell activation. Okay. How do we activate a B cell? The B cell has to be activated, right, by a T cell. Okay. The B cell has to be activated by a T cell. And what kind of T cell is going to activate a B cell? It has to be a helper T cell, because a cytotoxic T cell does not activate anybody. It is the assassin. It has the ability to kill the virus cell, so it doesn't need to call for help. So if you ever get any question about any kind of T cell trying to activate another cell, it is definitely a helper T cell. That's why they're called helpers, because they activate other things. So a helper T cell can activate a cytotoxic T cell, or like we're about to see, it can activate a B cell. Okay. So how does it happen? Well, first things first, the helper T cell has to be activated, which is what we just looked at on top, right? So when you're studying this, let me actually clean all of this out, make it look clean. When you're studying this, right, start from here, use your antigen presenting cell to activate your helper T cell, right? Then come down here. Now your helper T cell wants to activate a B cell. Maybe because in this case specifically, we want to target this organism using antibodies, right? That's why we will do it. So that's one first thing that happens, okay? And your B cell, right, can also carry out receptor-mediated endocytosis with the use of antibodies, okay? And now the B cell functions as an antigen-presenting cell in this case, because we said it here. It can do the same thing, right? Like dendritic cells. It can function as an antigen-presenting cell, but obviously it's going to be using MHC2, okay? Because this is an antigen that came in from the outside. And then same things, right? T-cell receptor CD4. But here's area of focus. It's the CD40 ligand and CD40, like we just talked about. The exact same thing with your macrophages, okay? The CD40 and CD40 ligand says that what we need to do here is activate the B cell, not activate the T cell. This is a very subtle difference, and I hope you get it. Because when you look at these two pictures, they look almost the same, right? Because the top half of it is pretty much the same. But what I want you to remember, let me simplify this, is the direction. In this case, the arrow that I'm going to draw is the direction of activation. This is what is happening. I am activating this way. And this same thing right here, and this one, I am activating this way, okay? So the bottom line is, if I am active, so the first part is always the same. MHC1, MHC2, T-cell receptor, CD4, CD8, always the same, okay? But here's what you take away from it. If the question states we are activating a T-cell, then I need what? B7 and CD28 in that lower segment, okay? But if the question says a T cell is activating somebody, then I need CD40 ligand and CD40. I hope you caught that. Very important. It just comes down to the wording. Are we activating a T cell, or is a T cell activating someone? If I'm activating a T cell, I need what? B7 and CD28. But if the T cell is activating someone, then I need a CD40 ligand and a CD40, right? And obviously, the CD40 ligand will come from the T cell. The CD40 will come from whoever I am trying to activate. In this picture, it's a B cell. But, like we said, where is it? In this case, it could be a macrophage. So right here, what we have here is a story of a T cell trying to activate a macrophage, all right? To get it. So remember, whenever a T cell is activating someone, I need CD40 ligand and CD40 interaction. So I can see it in macrophages, and I see it here again, right, with my B cells, okay? So that's just the switch. So when you get these questions and the answer options, they have a whole bunch of stuff, right? They have A, CD40, B, CD28, B7, and all that. Let it come down to what are we doing exactly? Am I activating a T cell, or am I using a T cell to activate somebody, right? And that's the difference. Now, obviously, if I'm activating a B cell, then we know B cells would eventually give us plasma cells that would now make antibodies. Then now we can decide what kind of antibodies do we want. If it's IgM, then we stay put. But if it's E, A, or G, then we can class switch. And that's it. That's it, really. Okay. All right. So let's talk about your antibody structure real quick. And I'm not going to spend too much time on antibody structure because the bulk of it is straightforward. But remember, what you have here is you have your constant segment and you have your variable segments, right? And what you need to know is what they mean and what they represent.
Excuse me, please. I have a question.
Yeah.
Yeah, please. What is the importance of class switching from IgM?
Well, the importance that we're going to, I think it's probably on the next page. As you can see, different antibodies have different functions, right? So the thing about it is, if I have IgM, but what I'm trying to do is on my mucosal surfaces, then I need IgA, right? So it means we can't always stay as IgM. You have to change to what you need. All right. So that's what you're going to see here. Now, IgG is a useless one, right? Unclear function, so nobody cares. But each one of them have their unique roles. So it just comes down to what are we about to do and what do we need to do it? Okay. If we need IgG, then we switch to G. If we need A, then switch to A. All right. So like A is usually in your mucous surfaces, right? Your mucous membranes. If you need to be protected, right, on your mucosal surfaces so you don't get like some mucosal infection like Giardia lamblia or something like that, then you need IgAs. IgM is not going to do that for you. So what do? You switch to IgA to protect yourself. All right. So that's the whole concept behind it is, I'll do it here again. Your IgM is a parent one that could switch to what you need. Okay. So even with your antibodies, you have to first of all understand, the structure of an antibody and the roles that each part plays, right? Because you have what's called your FAB segment, right? Which is your variable segment. And you also have what's called your FC segment. Okay. So, and sometimes it will give you a question and it will just be a random picture of an antibody, right? And then they'll put answer options. They'll say this is A, this is B, and they'll say this is C, and they'll ask you where does complement bind? And obviously the answer is going to be B, right? So you have to really know the different parts of the antibodies and what binds to the different places. So let's start off with the FAB segment, okay? So the FAB segment, the word here is that it determines what's called your ideotype. That's the key word, right? So the ideotype means it determines what kind of antigen am I going to bind to? Am I binding to a strep antigen or am I binding, right, to a staph antigen? That's what that means, okay? So that's your FAB, and that's where you have your antigen binding site, all right? So if you look at it right there, your antigen binding site is going to be right there, okay?
Hey, Doc, could you please repeat that?
Sure. So I
Thank
said
you.
your FAB segment determines what kind of antigen you're going to bind to, all right? So if you get a question about an antibody, right, and it says this is an IgG antibody, but we want to figure out if this antibody binds to staph or if it binds to strep, the answer is going to be in the FAB region, right, which is right here, your antigen binding site. That's FAB.
Excellent. Thank you so much.
No problem. Now, on the other side, your FC tells you what kind of antibody it is. So your FC is what tells us the results of our class switching. Okay, because from the FC, I can tell, is this an IgG? Is this an IgM? Is it an A? Is it an E? Right? The only way I can tell that is to look at my FC, right? And the word there is your FC determines what's called your isotype. So isotype tells you what kind of antibody is it. It doesn't matter if it's for staph or for strep or whatever. The bottom line is this an IgM or is this an IgG? Your FC portion tells you that, and FC is usually at the tail. So FC is at the tail, FAB is at the head. So it's almost like in alphabetical order, ABC. AB at the top, C at the bottom. Okay, so remember that. Now, the other thing to remember is that midway in the FC region, right, is where you have your complement binding. It's usually right there in the middle of your FC region. Okay, so if you get a question on that, right, where does complement bind? FC, all right? As we move forward, you're going to see things like your FC receptors, right? Where do your FC receptors bind? When an antibody wants to bind to something that has an FC receptor, the FC receptor is going to be right there. That'll be your FC receptor.
Excuse me, please. What do you mean by these isotypes? What does that mean?
Isotype just means what kind of antibody is it? Is it an IgM, AD? What kind of antibody is it? That's it.
Okay.
All right. And don't forget, that's going to be from your FC region. Okay. Now, other key things to remember is, before we look at the functions of antibodies, is how do we generate diversity? Okay. How do we generate diversity? So there's going to be what's called your antigen independent generation of diversity and antigen dependent. Okay. So if it's antigen dependent, then, right, it has to affect a region that has to do with antigen binding, which is my variable region, which is my FAB. All right, my FAB is my variable region. So when you look at it, part of what happens is there's going to be a somatic hypermutation of my variable region. So this is starting from the gene level, is we mix and match the FAB segment to determine what kind of antigen I'm going to bind, okay? And once that is determined, if this makes up his mind that, you know what, after all that hypermutation and recombination, I only want to bind to a specific strain of strep, then it's never going to bind staph, okay? But the other part to it also comes down to a little bit of isotype switching in the constant region as well. Okay, because there are specific antigens that work in specific places. So for example, if I have an antigen that likes to walk on mucosal surfaces, then I need to make sure that this FC region is the FC region of an IgA, right? For starters, that's my isotype switching. Then I know, okay, as an IgA, I'm going to focus on the mucosa. Now, what are my mucosal infections? Then I go ahead and do some more variations here to say, you know what? I want to go after Giardia, right? Then now you know that this is an IgA that protects you from Giardia lamblia, all right? So that's what's called antigen dependent. Antigen dependent just means that when we're making this antibody, the focus at the end of the day is to attack a specific kind, right, of antigen, right? And the key word there is it gives you specificity. Okay. So whenever the question says specificity, specificity is talking about antigen dependent, right? How do I make something specific for an antigen? How do I make a specific antibody that will attack staph? How do I make a specific antibody that's going to attack a kind of strep? That is going to be these two scenarios. Okay. Now, your antigen independent is for diversity. It's not for specificity. It just says, how can we make different antibodies? It doesn't matter what they go after. We just want to make different antibodies, right? And this is when you have what's called your recombination of the chains in your genes. So it could be a VJ recombination or your VDJ, okay? So these right here, VJ and VDJ, these are really gene recombinations. So it goes down to a little bit of kind of like I'll call it genetics and biochemistry, right? And more biochemistry. So all you're doing is just rearranging the genes to come up with a different protein at the end of the day, all right? But all you need to know is that the genes, right, these chains have names, and that's your V, your J, and also your D, okay? So V obviously means you obviously have some variable right there, all right, on your, and then you can also have your heavy chain and your light chain. So when you look at your antibody, the heavy chain is this middle one, and the light chain is on the outside. So light chain is usually for your J. So how you rearrange your J can also tell, okay, we're going to make a different antibody now. So that's one way, all right? And then the other way could just be during the DNA process is recombination of your TDTs, right? And then also random combination of heavy chains and light chains. So in summary, to put this in simple terms for you, this means if you look at this antibody, right here, it's almost like playing cards. You have a deck of cards and you just keep reshuffling them, right? You reshuffle it, that's one product. You reshuffle another product. We don't care about what antigen it goes for, because at this point, we don't care. We're just trying to make as many possible antibodies as possible, right? So all of these are just reshuffling of genes. Easy way to look at it, okay? So when all is said and done, right, what are the functions of your antibodies specifically, right? So we know that, you know, your antibodies are for fighting infections, right? And we know that there's some of them that can actually fix complements, all right? But other than that, what are some specific things that they can do, right? One of those things could be neutralization. A way of protection could be to offer you neutralization where the antibody binds to the organism, right? So the pathogen there, and actually stops it from landing on your surface, right? So because if these antibodies are gone, this bacteria lands on your surface, now you're infected. So that's one way. Another way could be opsonization. Opsonization means it coats the bacteria and makes it easy for a phagocyte to eat up that bacteria. It makes it easy, right? So this makes endocytosis or phagocytosis easier, right? So it's almost like it's seasoning the bacteria to make it more tastier for the phagocyte to eat it. That's opsonization, right? So we need antibodies for that. Okay, and then also finally, we need antibodies, right, as you're going to see, for complement activation, right? But now you're also going to realize that it is not every kind of antibody that can activate complement, right? It is specific ones. And let me see, I really want to make sure I go over the complement pathways before we end today. So I'll skip over this one. So take your time and just come and run through your antibodies, right? So obviously the main ones is going to be IgM and IgG, but remember the original ones that were present in the plasma cell is IgM and IgD. But like I said, IgD we can forget about because it's of no use, unclear function. We find it on the surface, right, of the B cells, but that's about it. Nobody cares about it, right? So the main one's going to be your IgM, all right? But then IgM can class switch to an A G, or an E, okay? So when you think about E, I always think about your allergic reactions, right? Your mast cells, your basophils, right? And then your IgG, right? So I'm just going to highlight the buzzwords about this, right? IgG number one is an antibody that can fix complements. You must remember that. And we're going to talk about it because we're talking about complements next, all right? It's an antibody that can opsonize bacteria, right? It can also neutralize bacteria, toxins and viruses, like in the picture we just saw. But also, very importantly, you can't forget this part. It is the only one that can cross the placenta. It is the only one that can cross the placenta. So it can travel from mother to child. And we're going to see scenarios where this comes in handy. Okay. So that's your IgG. And then something else we're going to see in hematology is that it is associated with your warm autoimmune hemolytic anemia, right? Your IgM is the cold one. IgG is warm. Okay. So then IgA, we said this is all about your gut surfaces and your mucosal surfaces, right? And then your IgM is your immediate one in response to an antigen. So usually in acute scenarios, that's going to be your IgM right there, okay? And also, other thing I'll mention when you're starting this to highlight and put in your notes and try to remember is some things that seem like it's not important, right, are actually important. You will see them in questions. Like, for example, it's important to know that your IgA usually occurs in pairs, as you can see. It's usually a 2-for-1. IgA likes to do that. Okay, so don't forget that when IgA is secreted, right, it's secreted as a dimer. So dimer means there are two of them together, right, linked together by a J chain. Also remember that your IgM is a pentamer, which means that 5 of them like to go together. Okay, so when it gets secreted, right, it's a pentamer, which means 5. So those are the only ones that do any kind of grouping. The other ones are just the way they are. So IgA, dimer, IgM, pentamer. Okay.
I have a question.
Yeah.
How would, let's say it's a pentamer as an example, or this type of, how does that type of question look like? How does it present?
So, I mean, so this kind of question just comes down to, do you know the structure, right? So it could be, for example, it could be talking about maybe a cold hemolytic anemia, your cold agglutinin disease, right? And now you have to know that cold only happens with IgM. And it could tell you there is an antibody involved in this process, in this cold autoimmune hemolytic anemia, right? In what form is that antibody when it's secreted, all right? Then you're gonna have monomer, dimer, pentamer. And what you have to know is, well, if it's cold autoimmune hemolytic anemia, then the only antibody that's going to do that is IgM. And IgM is a pentamer, and then that'll be your answer. Okay.
Yes, got it. Thank you.
All right. And I think I'll come back to this when I link. I want to talk about complements real quick. All right, and your complement pathway, because I know this drives super crazy. All right. So the complement, from what we've seen so far, right? The first mention of it we've seen is that it attaches to antibodies, right? And we know the site of attachment to your antibodies is somewhere midway, right, in your FC region, right? So don't forget that. That's where your complements can bind. All right, so this is my FC and FAB right there. So what are complements? They're proteins as well. Now, don't forget, antibodies are also proteins. That's why they're called immunoglobulins. They're proteins, globulins. Complements are proteins as well, but they are also immune proteins, just like antibodies, okay? But they're not adaptive. They're innate, which means immediate response is where they can come in handy, right? So they play a role in your innate immune system and in inflammation, okay? So when it comes to complements, we always talk about two pathways, all right? Well, it's more than two pathways, but the two main ones is going to be a classic pathway, right, and your alternative pathway, all right? Now, why am I talking about this now? Because I want to connect it with antibodies. We said some antibodies have the ability to fix complements, but not all of them. There are only two antibodies. If you come down to the notes here, when you're going through this, right, look out for it. For IgG, it tells you here that IgG can do what? Fix complement. If you scroll down to IgM, it will tell you that IgM can fix complements. I guarantee you, when you go through this, you're not going to see that anywhere else, because these are the only two that can fix complements. So all this stuff we talked about, complements attaching to this FC region, if you see that, then you're looking at either an IgG antibody or an IgM antibody, right? That's one. Two, whenever you see that, you must link it to your classic complement pathway. That's why I love the mnemonic. This worked for me. GM makes classic Cas should remind you that when you get a G or an M antibody, you get into what's called your classic complement pathway. What does that mean? It means that if you look at it here with your classic pathway, it says I have my antigen antibody complexes, but as you guys know now, what antibodies am I looking at here? Is IgG, right? And IgM, because GM makes classic Cas. If I can get IgG or IgM to bind to some antigens, right, they can go ahead and now fix complements on their sides. And what that will do is that would cause the production of more complements. And when you make more complement, then you can fight things more. That's the whole essence of things, right? So with the complement pathway, do not lose sleep. You don't have to lose sleep trying to memorize the exact sequence of, well, it goes to C1 and then there's C4 right there and C2. No, you don't need to lose sleep over that. What you need to remember is, all right, I have complement numbers 1, 2, 3, 4, and all that, right? Remember that the classic starts with C1. It's the beginning. It's the end all be all of your complements. It's the classic one. It starts off with 1. All right. So that sounds good. Classic 1, C1. Okay. And your alternative one will start from 3. But the bottom line is, it doesn't matter where you start from, you're just going to keep propagating and making more complements, right? And at the end of the day, if you keep going all the way, you could end up in this region here, right, called your terminal complements. Okay, and your terminal complements is your C5 to C9. Okay, C5 to C9. All right, And C5 to C9, what they like to do is, if you can go all the way there, right? Now the complements are doing different things, right? They're helping you fight the infections and all that. But if you can get all the way to C5 to C9, C5 to C9 is also called your MAC, right? Not a MacBook, not the makeup, but your membrane attack complex. That's what MAC stands for. Membrane attack complex. Okay. And what your membrane attack complex does is, like the name implies, it attacks the membrane of the bacteria that you're trying to fight, destroys that membrane, and the end result of that is what? Lysis and cytotoxicity. That is how complements can kill things, okay? Especially when you get to the very end. Now, one thing you must also remember is that your terminal complement, you know what kind of bacteria it likes to destroy? It likes to destroy Neisseria. Probably not spelling this right, but you guys know what I mean, right? Your Neisseria gonorrhea, Neisseria meningitis, your Neisseria infections, your C5 to C9 likes to destroy them. So the question could be, if for any reason I don't get my C5 to C9, then what happens? You become prone to Neisseria infections, right? And probably, yeah, your Neisseria species, recurrent infections with Neisseria could cause that, okay? However, what you need to know individually is that as we make these complements, they all have, well, not all of them, there's specific ones that have specific functions, right? And it's all right there for you, okay? Starting from right there, okay? So this is what you need to focus on and memorize. Don't lose sleep trying to know the exact pathway of this. No, don't worry about it. All you need to know is, how does it start, okay? And how does it end? It starts in the classic pathway with the GMX classic cards. IgG and IgM gets me into my classic one, C1. And I've started, period, done, right? My alternative one, right, is an alternative. It is not the main starter. So it's going to start at what? C3, okay? It's going to start at C3. And my lectin, right, is going to start at something that is C1-like. It is not C1, but it is C1-like, okay? So that's what you need to remember of how we get started, but individually know the functions. So as I go along the way, if I get to a point where somehow, some way, I end up making a C3b, okay? The C3b has one function that it helps with, and that's what? Opsonization of bacteria or anything that is opsonized. Okay, so C3b will help you do that. Okay, and if you get C3a, C4a, right, and C5a, okay, so your C3a, C4a, and C5a, if you look for them, you'll find them, right? C3a, right, C4a, C5a, those are your anaphylactic complements. That's all you need to know. Don't lose sleep trying to figure out where exactly you make C3A, where exactly you make C4A, right? So most important thing to remember is the functions of these three is anaphylaxis. Then your C5A also has another role, and its other role is it's part of your neutrophil chemotaxis. You have what's called your neutrophil chemotactic factors. All right. Now, what is chemotaxis? Chemotaxis is like taxi, being in a car, it's transportation. So neutrophil chemotaxis just means neutrophil transportation, right? It just simply means, how do I transport neutrophils from wherever they're having fun to where they're actually needed? Guess where they're needed? Where there's some inflammation taking place or needs to take place or an infection going on, right? So there are factors that drive neutrophils to areas where they're needed. They call them the neutrophil chemotactic factors. C5a is one of them, okay? So C5a, your interleukin, right? I can't remember if it's interleukin, I think it's interleukin 6, yeah. And your kallikrein, right? Double check on this, folks, when you can. But I think it's your C5a interleukin 6 and your kallikrein, right, are your neutrophil chemotaxic factors. So I usually go by the mnemonic silk. All right, C5a, interleukin 6, and kallikrein can help you drive neutrophils to the areas where they're needed. But why are we talking about this now? Because C5a, remember, it's a complement, and it can do that. And then finally, the last group is the terminal complements, right? The C5b to C9, which give you a membrane attack complex that can cause all the cytolysis, but cytolysis especially for Neisseria species. Okay, so that's one of the main things you need to know about your complements. Okay, now one other aspect that is tied to hematology, and we'll see this again, hematology, is your complements can actually function, right, as inhibitors, right? Well, no, not the, you can have inhibitors actually inhibit certain complements, okay? Because sometimes, like they always say, things have to be done in moderation. And we'll stop after this, right? I know we're over time, but too much of anything is not good. Complements, as you can see, are needed, right? For bringing neutrophils, for anaphylaxis, right? For membrane attack to destroy Neisseria. So they're good for destroying bacteria and all that. But sometimes they go above board and can begin to destroy you. Classic scenario, complements can destroy red blood cells and cause anemia. Okay, so there has to be a way to prevent these complements from doing things like that, from going ahead to destroy bacteria, to destroy your red blood cells, right? And that's why you need like inhibitors, complement inhibitors, like your decay accelerating factor, your DAF, which is also called your CD55. And then there's also your CD59 as well. We're going to talk about this in hematology. These are complement inhibitors to help inhibit complements. So what happens is if you're deficient in these, then you lose that protection, and now your complements can go ahead and destroy your red blood cells, right? So the disorder that comes out of this, right? Don't worry, we'll talk about this when we get to hematology, is your paroxysmal nocturnal hemoglobinuria. Okay, also called your PNH. The PNH is pretty much complement-mediated red blood cell damage because of the deficiency of your complement inhibitors. Okay, all right, so that's where we'll stop for today. All right, any questions before we wrap it up? Yeah, sorry we're over time, but just wanted to finish this.
Actually, when are you going to have this video available on Canvas?
Now the one from last class, did you guys?
This one that we're doing right now.
Yeah, but that's what I'm trying to figure out. Like, did you guys get the one from the last class yet?
Yeah.
Okay.
Yeah.
How long did that
I ended up emailing Dr. Hilboff, and he did that this morning.
Okay.
Yeah, it was posted, but it specifically, this lecture that you just did has a lot of really nice clarifying points that you touched on, and it's quicker to go back so you can watch the video and just get right to them. So I was just curious if you'd have it available now or like later this afternoon, like tonight or something like that.
Well, what I'll do is I'll go ahead and message Dr. Oleski right now and tell him to make the video available if possible tonight. Okay.
Cool. Thank you. That's very awesome. Appreciate it.
No problem. All right, thank you, folks, and have a good.
I want to ask something, please. This PNH. What is the connection with the inhibitors with PNH, please?
The connection here is that the inhibitors are supposed to inhibit complements to protect your red blood cells, right?
Yeah.
So if you have a deficiency of these inhibitors, like your CD55 and CD59, if you're deficient in them, then you can no longer block the complements, right?
Yeah.
What's going to happen is the complements will now go on and destroy your red blood cells.
Okay.
Okay. And when you destroy red blood cells, then obviously there's hemolysis taking place and you start seeing breakdown products of red blood cells in your urine. That's why it's called a hemoglobinuria, because you're destroying red blood cells and you're pretty much peeing them out because complements is destroying them.
Okay. So why did they choose to destroy this red blood cell probably in the night?
So that's a very good question that comes out, right? So the different theories. One of the theories is that the red blood cell destruction is actually not necessarily increased at night. That the red blood cell destruction tends to be more noticeable because there's less kind of urinary action at night because you're sleeping. So when you wake up, you have an accumulated effect, right, of all the red blood cell destruction, which is why they wake up with a dark urine in the morning. That's one theory.
Okay.
The other theory comes down to levels of CO2 and oxygen during sleep. Is that your altered levels, right, of oxygen delivery during sleep, right, can actually promote more hemolysis at night.
Okay.
All right. So those are the two different theories out there. And I think it's a combination of both for why your PNH symptoms tend to occur more at night, but really it's happening throughout the day. It's not that it's only at night the hemolysis takes place. Hemolysis takes place throughout the day when patients have this. It is just more pronounced at night because when they wake up in the morning, that's usually the darkest urine they have. So the first P of the day is so dark, and then the urine lightens up as the day goes ahead.
Okay, so I want to ask something. Are we going to continue on this immunology on Saturday?
No, I don't think so. I don't think we'll continue immunology on Saturday. I probably will have to move on to a different topic.
So have to read other ones on our own, right?
Right. So I always encourage read ahead, and if there's any specific question that is really pressing, I may try to answer it. If you bring it up in the next class, but
Okay.
just read ahead.
All right. Thank you.
All right, no problem. All right, thank you, everybody, and
All right, thanks. Have a good night.
Have a good night.
have a good night.
Bye-bye. Yeah.